Sure.
Good evening, everyone. Welcome to the Division of Cardiovascular Disease Grand Rounds. We have an unusual topic today, not a traditional medical topic, but very, very important. It is on medical documentation. And we are honored to have our presenter, Dr. Robert Woodman, who is joining us from California. Dr. Budman is a Chief Medical Information Officer with almost 40 years of clinical experience and also 20 years of leadership experience in primary care practices, hospital groups, integrated delivery networks, and multi-hospital systems deploying new workflows and electronic health records. Currently, he is a full-time physician executive at Nuance. He is board certified in family medicine and clinical informatics. In addition, Dr. Budman was a clinical professor of family medicine at the University of California with a teaching award from his students. He has extensive experience in utilization review and clinical documentation excellence. And he is adding his broad multi-service line experience, assisting physicians and organization success with technology for efficient and compliant documentation. Welcome to New Jersey. Welcome to our Grand Rounds. And we're looking forward to your presentation.
Thank you very much for that warm welcome. I'm actually in Jacksonville, Florida now. I enjoyed Southern California.
Yeah, for geographical, mishap.
That's okay. And an interesting claim to fame is in 1998, I was the expedition physician for the crew that brought up the big piece of the Titanic from the bottom of the ocean. So it's always fun to look that up and talk about it. It's very exciting. Anyway, I am going to talk about documenting for cardiology success in terms of documentation that makes a difference, particularly for coding, billing, quality issues. These are the must-be written diagnoses. I'll go through this presentation very fast. I want it to be fun. I want it to be informational. I don't want it to be boring or anybody to fall asleep. And you will get a copy of all the slides when I'm done. I'll send them to RWJ Barnabas through your CDI team. And I'm going to be there Wednesday morning in New Brunswick, actually working with some of the docs on their Dragon Ambient experience. This is the AI that automatically writes progress notes. Anyway, I'm going to turn off my camera and switch to presenter mode, and we'll get started. Hang on one second while I switch it to presentation mode, and we will get going. Hang on, I'm going to switch one more thing. There we go. So documenting for cardiology success, the must-be written diagnoses. And why do I say diagnoses? Because it's too easy to just focus on the principle or admitting diagnosis, and that is not enough. That is a lot of what we'll be talking about tonight. The importance of your documentation. Everything around clinical documentation integrity that you see here, these 6 balls, quality metrics, present on admission, hospital-acquired conditions, patient safety indicators, denials, hospital ratings, very important, medical necessity and length of stay, and of course, ICD coding and DRG assignments. When you have all 6 of these, on the left, you see it equals dollars. It's important, but it also equals quality. If you miss any of these, you run the risk on the right side of losing money and losing quality scores. That's why it's so important to understand these 6 components of really good clinical documentation. So in the agenda here, very quickly, again, clinical documentation, why it's important. In this case, we're going to focus on cardiology related documentation, some of the hot spots and keys to success, why it's important to you, because it affects your provider quality scores. It avoids queries. Nobody likes queries. They're time consuming, but they're necessary to make sure things are clinically valid or not missing within the records. And it limits denials. You always hear about that. And it's very costly and time consuming for RWJ Barnabas. Your notes lead to coding directly. Coding leads directly to quality scores and, of course, billing, because coding and billing and quality scores, DRGs, all go together, particularly on the inpatient side. That's where a lot of our focus is going to be today. And we'll go through some quick studies of what relative weight and CCs and MCCs are. Very briefly on hierarchical condition categories. And we'll spend some time on all important O to E, mortality ratios, and severity of illness. And then some work here on quality PSIs, hacks. And I put here the physician advisor role. I meant to take that out because we were talking to them a few weeks ago. And then a little bit about what documentation and coding queries may carry forward for you that are necessary for documentation that could be missing or not clear in your medical records. Really, what I want to do is I want to avoid queries. In other words, reduce your queries. And I want your notes to be better. And I'll explain with some anecdotes why that's so important. No one likes queries ever. So be attentive to the learning and be wise to these documenting points. Again, we're not seeking perfection here, but I'm trying to move the needle significantly for all of you. So the importance of what we document. Well, it determines how we code, how we bill, and again, how we avoid denials, and especially audits. Obviously, we want to only put things that are truthful in the chart. We don't want audits. Timeliness is really important. We want all this work done, obviously, at the time of discharge, or whatever your policy is that's to get your discharge summary, 24 hours or 48 hours, whatever it happens to be. If we learn how to document well, not only will we be timely, but we'll avoid those queries that we discussed as well. We've all had queries from time to time, and that means going back into the EHR, reviewing a chart that maybe you discharged somebody days ago. It's not easy to remember everything. If we get ahead of that curve, we can avoid those time-consuming tasks. Thoroughness. It's really important to document thoroughly, and I'm going to go over some examples of that. And of course, we want notes that are logical, contain evidence, have meaningful plans. That leads to good care. And guess what? It's team play, because if you don't do it, someone else on your team is going to have to pick up that work. And that's never good. It really is a team effort. So there's 3 really high quality measure scores that are run across the nation. They're all important, but present on admission is very common. Patient safety indicators are very common. And of course, the worrisome hospital acquired conditions that nobody wants. And if you document well, it'll help you avoid a lot of queries and inquiries into these key quality measures. And then at the bottom, you see, don't forget about core measures too, like sepsis bundles, venous thromboembolism, etc. All come from great documentation. There's also a whole host of other measures. It keeps us busy on the administrative side. Length of stay, of course, hits you on the inpatient side, but cost per case and readmissions, HCAHPS, the quality surveys and satisfaction of your patients. Of course, queries and high rates, and are they done within the allotted time? Nobody wants to be fined or on the CMO's list for why didn't you answer the queries. And then, of course, clinical quality measures, readmissions. Did you do the beta blockers? Did you do the statins? Did you stop the antibiotics? Did you avoid the UTIs and take the catheter out? All those sorts of things are so important. Again, these very much rely on really great documentation. So we need to dig into that a little bit more. So let's really dive into some of the digital secrets of cardiology notes. And I've tried to highlight throughout this presentation in yellow some of the things I really want you to pay attention to. Put all the diagnoses in the note at admission. Why is that important? So, for about 3 or 4 years, I worked in Atlanta, Georgia. It was a community hospital system. I was the chief medical information officer for the entire system. And we noticed pretty clearly that we were losing money on surgical admissions. Why was that? Well, these patients were coming in, and it was a secondary, tertiary center for cardiac surgery, that they would be coming in for mitral valve repair or aortic valve replacement, whatever it happened to be. Uh, and what we noticed was, wait a second, if we're telling folks that we have a high case mix index, in other words, we've got higher DRGs for the amount of discharges that we have on a yearly basis, why are we not making the money we should be making? Well, the problem was, if these patients are that sick and they only have one thing on their admission note, where are we missing? Well, we were missing diabetes and hypertension and chronic kidney disease and obesity. These are really crucially important. Now, a lot of people would say, well, wait, I'm on the CT service and the patient's coming in for, their heart valve replacement. I don't know all this stuff. Well, I would wager that probably you have residents or mid-level providers, nurse practitioners, and physician assistants who are helping with the admission process. And we quickly found at our hospital that if we educated the attendings and the residents and the mid-level providers, guess what happened? We started getting all of these diagnoses in the chart, and we drove up our DRG, and no joke, across about 11 or 12 hospitals that we had at the time when we instituted that education program, it netted about $30 million to the bottom line. So all the diagnoses in the note or admission are probably the most crucial thing I want you to take away from this. And I'm going to take it one step further. Physicians are great at diagnosing hypertension and heart failure and obesity and malnutrition, but guess what? You have to be specific. You have to say poorly controlled insulin dependent diabetes with retinopathy, nephropathy, and neuropathy. And you need to say poorly controlled hypertension with whatever secondary problems it may have, stroke, kidney disease, or whatever, and moderate to severe depression, and moderate to severe malnutrition. And if you don't know, get a consult, because if something crops up new on day 2, 3, or 4, maybe a consult came in from nutrition, or the patient had a TIA or a stroke, make sure all those diagnoses are added to. And look, we all know some of these patients have 10, 15, 20 problems on their problem list, but I need to know at hospital admission what is actively managed. And guess what? If you give them a hypertension medication and you're giving them insulin and you're putting them on a low calorie diet, you're treating them. You are managing all those problems, and you will get paid for it, and you will get those bullet point number 3. Why am I telling you this in such excruciating detail? Because there's secondary diagnoses that matter, particularly major comorbid conditions. These are the acute respiratory failures, the acute kidney injuries, maybe the acute strokes, and things that happen not every time, but frequently on hospital admissions. And it does make a huge difference in your quality scores and your DRGs and ultimately what you get paid. And we'll go through some calculations of that. So again, we're all great at the admitting diagnosis or the principal diagnosis, acute congestive heart failure or acute aortic valve stenosis, whatever it happens to be, but we need to get the other diagnoses. So last time I'm going to say it, put all the diagnoses on the chart that you're managing. So important reminders. So the Uniform Hospital Discharge Data Set tells us the importance of reportable secondary diagnoses, okay? If you do put them on, they require at least that you've clinically evaluated it. It could be as simple as a blood test. It could be as simple as an oxygen level. It could be as simple as a glucose level. but it's important. You've also got some sort of therapeutic intervention. You're putting them on oxygen, you're giving them a medication, you're doing a diagnostic procedure, maybe a chest x-ray, maybe a CT scan, maybe venous plethysmography, or something that changes their length of stay, like an added new diagnosis. And the resources used to take care of the patient. You've put them in the ICU, they need cardiac monitoring, they need extra nursing care, you're getting consults from specialists. So just remember that in terms of when I say it's a new diagnosis and you change their medication, you're managing them in some way. Be aware of all these other things that also count as management. So we want a little bit of evidence, and we want a little bit of treatment or intervention. Fairly straightforward. So we're talking about what are the principal diagnoses that brought the patient in the hospital and the secondary diagnoses. Quick review here. Principal diagnosis may be the reason for admission, but it really is the most acute, severe problem that the patient is in for hospitalization. So you may bring them in for pneumonia, but eventually you might diagnose this as sepsis. Or you might bring them in for a TIA, but it ends up that they have a stroke or they have some other malady, whatever is the most resource intensive problem that's made them the sickest and requiring the most attention. Secondary diagnoses are everything else, and they do matter. It's the crux of our day in this discussion right here. It is a little bit harder because it requires a little extra work, but do be mindful, especially as attendings and leaders of your units, that if your docs are just putting one or two diagnoses, but they've got hypertension, diabetes, chronic kidney disease, moderate depression, moderate to severe malnutrition, or any of the other things that may be cropping up, rheumatoid arthritis, multiple sclerosis, all of these multitudes of diagnoses that are being treated with a medication, and you're following them on with labs, they need to be listed and they need to be carried through the medical record to the discharge diagnosis. This is absolutely crucial to RWJ-Barnabas survival. Why? Because of the coding and the reimbursement. Again, we're going to go through some calculations. But when I first started working with RWJ-Barnabas about 4 or 5 years ago, the leadership kept telling me, we're an academic institution, we're a university-based center, we're growing in size, we're a big component of healthcare in New Jersey and beyond, is we want to prove through our quality that we're the best. And the only way you will ever prove it is, guess what? Through documentation. It's going to be from your notes. It's going to be from your ICD-10s. It's going to be from your diagnoses, and it's going to be codable from your progress notes, from your admission note, your progress notes, your consults, and your discharge summary. It's really absolutely true. So in yellow, secondary diagnoses count. They must be in the chart. So let's go through some things really important. And lucky you and lucky me, unfortunately, and lucky CDI team, it's tough on them, is CMS likes to change this stuff every year. But MCCs, and here we have cardiovascular MCCs, there's thousands, hundreds of MCCs, but these are major comorbid conditions. They're not just comorbid conditions. There's a lot of those, but these are the major comorbids. Think acute, think deadly, think really intensive resource use when they get admitted. So remember, acute, they're present on admission often. Make sure you note that, and we're going to go over that again in a couple more slides. And where's the location of them in terms of right, left, anatomy, whatever it happens to be. For example, hey, the patient's got an aneurysm. Well, you tell me they have an aneurysm, but there's a lot of different aneurysms. So where is it? Is it in the right or left vertebrobasilar artery? Is it in the aorta? Well, if it's in the aorta, I need to know if it's ascending or descending or, abdominal. Really important to put this level of detail in your notes. Think medical detective. As I was an attending for many years, and every time someone asked me a question, I would become the medical detective. Really simple stuff. Oh, you eat ice cream? What flavor? How many times a day? How many days a week? Can you afford that? Probably not. So stroke, same thing like the ice cream. What kind? How often? Where? When did it happen? You need to know. You have got to be, I always say the best physician is a medical detective. They know how to ask all the right questions. And if you look at this list of MCCs, the major conditions, you can look at them and say, these are people that have a high risk of dying. So acute systolic failure, coronary artery dissection, aortic dissection, endocarditis, all of these, shock, VFib, you name it. But guess what? There's even more. Look at all these. We've got acute embolic and thrombotic diseases, unstable angina, arrhythmias, atrial fibrillation, possibly out of, sync, cardiomyopathies, of course, hypertensive crisis, pericarditis. These are all the biggies. Okay. We're not talking, an arthritic knee. We're not talking, a stub toe. These are the big resource intensive illnesses. And guess what? There's even more. Oh, I thought I had a third one. Maybe not. So you get off lucky with two. So let's dig a little deeper into some more secrets for better notes, because again, they lead to better care. It's communication across the care team. I mean, you wouldn't want to admit a patient for a valve disease and not everybody knowing that they've got diabetes, hypertension, and chronic kidney disease, would you? It's important for coding, but it's also important as care team communication. Again, it'll avoid queries because nobody's going to come by and say, oh, you put this patient in for pneumonia, but it looks like they've got all these abnormal labs and they've got crashing kidney and liver. They're going hepatorenal. Do they have sepsis? Or, do they have severe sepsis? Or are they in septic shock? Again, documenting really well, all the evidence helps. So some of the ones we're going to go over very quickly here is going to be CHF, MI, dysrhythmias, valvular disorders, the cath lab and interventional cardiology, and then CT surgery. Again, I mentioned this secondary diagnosis, how important they are for CT surgery. And of course, the one that nobody likes is complications, but we'll go through them because stuff happens, right? So let's look at CHF. It drives us crazy in the review world when we say the patient's got CHF. That's fantastic, but you got to be a medical detective, because if they've got acute systolic congestive heart failure with severely reduced ejection fraction and it's new onset, it's very different from mild chronic diastolic failure, where you might be managing them with one or two medications, dietary restrictions, cardiac rehab, versus acute systolic heart failure. And guess what? Like I mentioned before, I need to know the location. Is it right? Is it left? Was it present on admission? This is the bane of us in the CDI world. It's really easy on the admission to say, well, it's there on admission, it must be acute. You know what? It's not that hard to say present on admission. Please, if you can teach your mid-levels and all your residents, just drill it into them. Is it present on admission or not? It's not that hard to put in the note. Was that pressure also present on admission? Yes or no? Was that pneumonia present on admission? Yes or no? Why? Because it might become a hack. They developed it on day 2 or day 3 because they were on a ventilator, who knows? Or they developed that acute kidney injury because they braided down and they were dehydrated, or they were on bypass for a long time. But I need to know if it's present on admission. It's not that hard, and we really need to drill that into our teams. And then again, if there's an etiology to any of these problems, particularly CHF, okay, you've got CHF. What the heck caused it? Was it hypertension? Was it coronary artery disease? Was it MI? Was it valvular? Did you rupture chordae tendineae? Was it cardiomyopathy? Is it congenital heart disease? I don't know if you don't tell me. So it needs to be on every admission. It might be in the past medical history, but when you write acute systolic heart failure and it happens to be the admission reason, or it's the second next most important reason for that admission because they came in for a valve repair, but they happen to have CHF2, I need to know why, what caused it. And then you have to look at things like risk factors too. They've got diabetes, COPD, CKD, smoking, genetics, whatever it happens to be, and make sure that you've listed the evidence. Usually it's pretty obvious. You've put the signs and symptoms. You've talked about what you saw or heard on exam. Maybe you have abnormal labs. Here you have ejection fraction, BNP, chest x-ray, ECG. I need that in the note. Ejection fraction, of course, reduced or preserved. So A, first of all, write it. Make sure it's written out. And then as best as you can, be specific. Because I can't tell you how many times I have had medical students tell me, I'm taking care of this patient with diabetes and CHF. And I'll be, oh, that's great. And then I start asking the questions. Well, guess what? If I've got diabetes that's well controlled on oral medications and exercise, and I've got hypertension that's well controlled by weight loss and avoiding caffeine and black licorice, that's not really a very sick person. But if they've got poorly controlled hypertension with CKD stage 3 or 4, and they've got diabetes with retinopathy, vasculopathy, and neuropathy, and they're non-compliant with their insulin, and their hemoglobin A1C is 10, that's a vastly different patient. That is why being specific is so important. What I like to tell my medical students is tell a story. When you tell me about a patient, you do a presentation, I should have a picture in my mind. Are they in a wheelchair? Are they bedridden? They've got ulcers all over their body. They can barely breathe and they're on oxygen. Is very different from an exercising person with hypertension and diabetes who's trying their best to be as healthy as they can be. That should be fairly obvious. Let's move on to MI. Documentation needs of MI. Again, it sounds kind of dumb. Is that an acute MI? I need to know. And it needs to be written. Or is it a subsequent MI? That means it happened within 4 calendar weeks. That's 28 days of a previous MI, because after that, for coding reasons, typically that means it is a old or chronic past medical condition. And guess what? Just like the other places, laterality, location, where's it? Be as specific as you can be. It is in which artery, it's in which part of the heart. Were there any underlying etiologies that might have led to the MI? And it says here, be effusive. It's okay. It's the most important part of the chart is the assessment and plan. Everybody's worried about, I'm going to pull in every x-ray and I'm going to pull in every lab and I'm going to pull in, 50 things off the problem list. I'm going to pull in all their social history. It doesn't matter anymore. What matters is 1 or 2 or 3 diagnoses that make a big difference. Don't forget any of them and talk about them in the assessment and plan. I have a patient who came in with an acute MI due to coronary artery disease with severe diabetes, poorly controlled hypertension, and CKD that went from stage 3 to stage 4. Their COPD is an exacerbation. That's a person who's going to die, and we're going to talk about that in a little bit. But it makes a huge difference in the chart. So you hear a lot of passion in my voice because I was a professor for many years and I was in utilization review and clinical documentation excellence. So if you manage any of these problems, put them all in the assessment and plan and tell your students, tell your doctors, tell your colleagues, I need to know everything. If you put it in the admission H&P, it'll carry through the chart to the discharge. If it happens on day 2 or day 3 and you put it in there, hopefully nobody's going to miss it when they do copy forward or they make their next note. Try not to be unspecified. Is it a type 1 MI? Is it a type 2 MI? Because you have to be able to show the etiology of where the ischemia, oxygen deprivation, or demand came from. You all know that. Your cardiologists and CV surgeons. Again, if they're hospitalized for a different reason, but on day 2 or day 3, they've got a lot of demand on them and they have a type 2 or a type 1 MI, we need to know that too. Dysrhythmia, documentation needs again. A lot of times these are chronic. They've got atrial fib. Maybe they're in flutter. Maybe they've got a bradycardia and they've got a pacer in, but I need to know. Just like POA, sounds familiar. I've got that here in the chart. Was that dysrhythmia present on admission? I don't care if they've had it for 10 years. I want you to tell me that it's present on admission. I don't want there to be any question in the documentation whatsoever. Because guess what? If they develop it and it wasn't present on admission, we're going to be asking you because it wasn't in the notes. I need to know if it's a history, was it pre-existing? So was it acute or chronic? And you see all the different dysrhythmia classes that are here: VFib, flutter, bradycardia, sick sinus, sinoatrial node dysfunction, WPW, sinus block, supraventricular tachycardia, whatever. Were there EP studies? I'd like to know about that, if they were done or not. Is it stable or unstable? How's their blood pressure? Do they need pacing? Do they need a balloon pump? Do they have a history of shock ever? Have they had an MI because of it? Have they been hypotensive? What interventions have they had in the past? Pacer, angio, CAB, coronary artery bypass grafts, valve repairs, implantable defibrillators, whatever. I need to know. Be specific about the rate as best you can. What was the old EKG finding? What is the current EKG finding? Is there a new EKG finding? I need to know that. And are they at clot risk? If they're at clot risk, I'm going to ask you as a medical detective, are they amenable to oral or pharmaceutical intervention? If they're not, are they on some sort of mechanical prevention, whether it's TED hose, something simple, or they've got mask trousers, or they've got some other inflatable device to help them, or are they just rubbing their legs every night with lotion? I need to know. Again, it's this business of, I need to know if it's present on admission. I need to know the specifics of the type of documentation they've had, how long, and what I've done for it. Get it on the admission, we'll be a lot better off. Let's look at some valvular disorders. Pretty obvious here. Which valve is it? There's 4 of them in the heart. Most of the time, there might be patent foramina as well. I need to know about it. What's the history of it? Was it at birth? Was it acquired? Was it rheumatic? Did they have endocarditis? They've been shooting up drugs in the street. Is it aging and it got calcific? Did they have a ruptured chorda? And is there insufficiency or stenosis? I need to know the very specifics. So again, when I tell the story to an attending or a colleague, I want to have a picture in my mind from the story that's told to me, from the results of the echocardiogram, from the results of the history taking, that I've got a little picture in my head of an aortic valve that's calcific, stenotic, and only has a opening that's 1.2 centimeters squared, bigger or smaller. I'll have a little picture in my mind. Tell a story so that I can see it. That's really what good documentation is all about. So severity comes into that. What are the pressure readings in the different heart chambers? What were the echo and angio findings? Remember, it also has to have a meat component. And this is a critical part of everything I've said, which is, hopefully all of you know this, but it's the monitoring, evaluation, assessment, or treatments of anything I do. I mentioned earlier, did I order labs? Did I do a medication? Did I order a diagnostic test? Did I do some other form of treatment like cardiac rehab or physical therapy, or change their diet? Any of these vast things that says I actually wrote an order to perform an action, that is management of an illness. I can write that diagnosis as one of my operating diagnoses, one of my manageable diagnoses for that hospital admission. Anything else is just history. If they've got a past history of rheumatoid arthritis that got resolved, I'm not going to treat it with anything. If they've got degenerative joint disease and is not bothering them on this admission, I'm not going to write it as one of my hospital diagnoses. But if they've got one of the things I mentioned, like kidney, liver, heart, lung, brain, diabetes, endocrine, whatever it happens to be, and I'm doing something for them, I have to write that diagnosis. I know it sounds like a lot, but I need them all. And then, of course, for valvular disorders, when they're in the hospital, what am I doing for them? Am I doing diagnostic studies? Am I putting them on anticoagulants? Am I doing afterload reduction? I'm prepping them for surgery, maybe. I need to know all those things. Again, you need to be effusive. This is what good documentation is. Good documentation is not every lab and every x-ray. It's discussion of the active medical problems. They're present on admission or not. Draw the picture in the story that you write so I can see it in my brain, and then I will understand the patient. Let's jump to cath lab and interventional procedures. Documentation needs here. Often it's the reason for admission for an acute cath lab, but sometimes they're elective. Again, I need a good history and physical. I do need, guess what? If they're an inpatient admission, not place an observation necessarily, not being seen as an outpatient, but for that inpatient admission, they're really sick. I need all the diagnoses that are pertinent. Makes a huge difference for all the things we're going to review in a couple of minutes again. What's the indication for that cath lab procedure? They had a STEMI, they had an MI, they had unstable angina, they got chronic angina, but they're not doing as well symptom-wise as I thought. They might be a candidate for surgery. They failed their stent. They've got heart failure now. There's an occlusion of a stent, tamponade. They've got a valve condition as well. Whatever it happens to be, make sure those documentations are in there. I've said this ad nauseum. Get all those diagnoses on the chart. And were they present on admission? Again, you need to talk about the specific procedure performed for the cath lab. How many vessels? What was the approach? You knew all this stuff. And then, of course, you need to regurgitate all the usual things. Hopefully, you're using Cupid in your Epic build, and it's telling you to record what were the usual findings, the pressures, what balloons did I use, how many stents, where did I place them, how good was my placement? Did I get 80 or 100% reduction of, the occlusion? Were there any complications? Did I use any dyes? What were the drugs? How did the patient do? Again, I need to read all this stuff, and in my mind, I'm going to have a beautiful picture of how great you did in the cath lab. Let's talk CT surgery. Documentation needs. Again, I'm going to go back to that very first slide. You do your admission H&P, whether you're the attending, the resident, mid-levels, maybe medical students, probably not, but usually attending residents or mid-levels. Surgical reason for admission is not enough. I should have put this in yellow, but you saw it earlier in the slide deck. You have to list every managed diagnosis. Probably CT surgery is your biggest case mix index set of patients. They're probably your highest DRGs in many cases, although I'm going to show you some examples of some other ones in a moment. Even if it's just one med, if it's just one lab, it's just one consult, that is management. And if you want to have the best CT surgery quality, you're going to put the present on admission. You're going to do all that stuff about history and location and all the diagnoses that you manage along with that presenting CT surgery problem, whether it's a transplant, a bypass, a valve procedure, whatever it happens to be. I need to know all the other things that are going to potentially be a risk for demise or a complication for this patient. Let's go through a couple of complications versus other conditions. Documentation needs that we know about from CT surgery. Sure, we have AFib. We did things in the heart, it irritated it. We might have post-op AKI. We may have post-op shock, vasoplegia, coronary artery dissection because we messed with their arteries, pulmonary complications. I'm going to go over insufficiency versus failure because this is also one of the banes of our existence because it's a difficult diagnosis and it's not easy to understand all the parameters. And we got to watch for patient safety indicators. Remember, some things happen to be cause and effect. If you have an MI or you have really severe heart failure, remember there's organs that are not getting the perfusion and the oxygenation they need. And if there's a complication, same thing, we're going to have problems, whether it's TIAs or strokes or kidney malfunction, etc. So some things are normal. We're sure of them. We've put it in our documentation that this patient was really, really sick. That helps protect us a little bit, but we do want to watch out for the other complications as well. Again, notes tell the story. And the most important aspect is, does the medical record show how ill your patient was to begin with? A patient coming in with an aortic valve problem that doesn't have all of the other attendant problems I've mentioned doesn't sound very sick to me. But the minute they have all the other things I've already mentioned quite a few times, then I recognize that that's a very, a very sick patient. Post-op atrial fibrillation. Again, age, genetics, do they have COPD, pulmonary problems, cardiac problems underlying, renal problems? I need to know about them. Are there operative risks? They got post-op AFib because I did valve surgery, or I did a bypass and there was a long clamp time, or I had to use post-op inotropes. Needs to be clear in the medical record. Again, show all the treatments. I did beta blockers, amiodarone, I did MAG, I did temporary pacing, I put a balloon pump in, I did anticoags. Was it paroxysmal? Was it a complication of some sort? Was there a history of arrhythmia to begin with? I've mentioned this before. I need to know it. Was that a patient who came in and got AFib because they were controlled before and they had it for many years, or was it something brand new? I need to know that. Post-op AKI, again, it's pretty common. Some may require dialysis, a couple percent. So we definitely don't want to see, I think it's 3 to 6% of cardiovascular surgery patients could get dialysis after the procedure. Did they have risk for CKD to begin with? I need to know if they were subjected to any nephrotoxins, hypoxia. Was there hypothermia in the surgery? Did they have low pulsatile flow on bypass? Was there a hemodynamic instability during the procedure? We're going to look for these. And remember, here's another important thing. We're going to show it very quickly here in a moment. AKI definitely leads to an increased length of stay and a risk of mortality, like many of the other secondary diagnoses that from this meeting forward, I'm sure you're getting some of them, but we want to get all of them, will from now on be in your notes. And remember, post-op AKI is PSI 10, which is post-op AKI, a higher rate needing a dialysis. We definitely don't want any PSIs. Try to avoid them. We have huge programs for all the PSIs, as you're well aware. Post-operative shock. Was it cardiogenic? Was it neurogenic? Was it septic? Was it hypovolemic? Was it anaphylactic? Was it SIRS? Was it vasodilatory? And we don't do distributive anymore. It really doesn't have a code. So when it's vasodilatory, you see an example below here, vasodilatory shock due to post-CABG vasoplegia. That I can document too. So I also need to know if it's compressive. Was there cardiac tamponade from effusion or blood? Was there graft compression or failure around the heart or the aorta? And I need to note the treatments. This evidence is usually very obvious, I know, because we do surgery or there's a preload or we do meds like our pressors, steroids maybe. We put pumps in, we give lots of oxygen, we put temporary pacers on. Usually these are pretty obvious, but they need to be noted, particularly for shock. And usually with shock, we tend to get pretty good about saying everything we're doing because we do a lot of orders on them. Remember, it's not okay to order something and let it sit in orders. It needs to be reflected in my assessment and plan. I once admit, this is a great example. I once had a patient was admitted for pneumonia, and the admitting diagnosis and none of the other patient's problems were on the chart. It just said pneumonia, plan, see orders. That is not documentation. Okay, that's frankly either apathy or laziness, but hoping someone else will put everything on there. Not acceptable. We need to have a list of all the action plans. O2, labs, chest x-ray in the morning, respiratory therapy consult. It's not that hard to do, and it makes a huge difference. And of course, there's coronary artery dissection. It does happen on occasion. It might be a result of advanced disease. They have got a lot of plaque. They've got a lot of inflammation. It may not have been the procedure. Did it happen after pressure was applied or stent was positioned? Did they put in a kissing stent? In other words, additional stents? I need to know this information. And then, of course, we're coming back to the insufficiency versus failure. Post-op pulmonary conditions do happen. Again, if I have a lot of risk factors noted in the chart, that helps me fight against a PSI, particularly if we know that they've got pre-existing pulmonary problems. Maybe they've got atresia. Maybe they've got pulmonary hypertension. Maybe they've got COPD. Maybe they've got bronchiectasis. It's important to know these. And of course, what happened during surgery? Were they on prolonged bypass? Was there an anesthesia misadventure? Was there an intra-op situation that happened? And of course, I mentioned the endless challenge of differentiating insufficiency versus failure. Remember, insufficiency is the risk due to any pre-existing lung issue, elderly, smoker, low O2, they've got tachyarrhythmias, their lungs sounded bad before on examination, I noted it. They've got altered mental status, they're slow to wean on their post-op intubation or oxygen supplementation. Maybe they've got hypercapnia, or they've got a reasonably good PF ratio. Again, if they're on high flow O2, but not on a prolonged intubation or having to be re-intubations under 48 hours after surgery, that's insufficiency. It becomes failure when you've got multiple conditions or valvular surgery with ARDS or lung injury, and they're intubated, and we know that their PF is really poor. But we want to try to avoid at all costs the PSI 11, that post-op respiratory failure, of course. We want to keep that number as low as possible. So again, list all the diagnoses. So what does it mean when you document severity of illness via your DRGs or assessment, observed versus expected mortality ratio? Let's dig into some of the calculations for a little bit. This is important. I don't expect you all to become masters of this. You're aware of it. It's more of a job for CDI and your executive leaders. We follow these closely in our safety-based programs. But severity of illness is calculated from the DRGs, and it's score based on, guess what? Said it a bunch of times, your patient's diagnoses and their procedures, of course, their age and other factors. But guess what? If I don't list all of the reasons that make them a severely ill person, I'm not going to be able to calculate their true severity of illness. It's important that we prove that RWJ Barnabas does indeed have a high severity of illness score because they've got lots of severe diagnoses. And I'm able to classify them through your documentation. Again, the story that we told with the words that you put in the electronic health record, that they were minor, moderate, major, or extreme, 1, 2, 3, or 4. And guess what? We get a different CMI rating, very similar to this, but the scoring for CMI is done from relative weights and per number of discharges. So severity of illness is going to come directly from the DRG and diagnoses, and the CMI is going to come from the relative weights and discharges. We're going to show that in a minute. Now let me talk about observed to expected mortality ratio. This is one of my funnest and easiest things to discuss. Remember, this is a mathematical ratio. So O is the numerator, E is the denominator. When that E denominator gets big, the ratio gets really small. So expected mortality goes up only one way: really sick patients with a lot of diagnoses. You and I are sitting here listening to, hopefully not too boring of a discussion of documentation about diagnosis, diagnoses that need to be in the chart. Because if we're healthy, we're sitting here right now, we might have hypertension, we might have some kidney problems. I probably have some dementia. I'm getting kind of old, but guess what? I'm walking and talking and nothing's actively being managed. My expected mortality is pretty low, knock on wood. My kids will probably kill me at some point. But if you've got all the things I mentioned, valvular heart disease, coronary artery disease, hepatorenal syndrome, chronic kidney disease, diabetes out of control, poorly controlled hypertension, all those things I mentioned, obesity, severe malnutrition, these are huge risk factors that people always forget. Again, document obesity and malnutrition if you can. Those people, guess what happens when they come to the hospital? They have a really high risk of dying. Their expected mortality goes way up based on their diagnoses. But guess what's important here? We used to have a hospital called, we joked, it was called Shady Grove, and we called it Shady Grave. It wasn't a really high quality hospital. They didn't have the resources to put in a lot of safety programs. They didn't have a lot of governance around their care. Their observed mortality was fairly high. There was a lot of people were dying. When the O number goes up, guess what? The ratio goes up because it gets closer to 1. And heaven forbid, in some hospitals, the O to E ratio is over 1. But guess what happens when I document really well and I take really good care of my patient, and the whole care team knows everything that's wrong with my patients, and I've got really good governance, and I take great care of my patients, take care of their hypertension, I take care of their diabetes, I make sure that their venous thromboembolism prophylaxis is in place, I take out their catheter quickly after surgery, and I make sure they got their post-op antibiotics, and I stopped them. Guess what? Those people don't die. They don't have complications. They've got a much lower observed mortality. And what happens when I have a low observed mortality and a high expected mortality ratio? Because I documented really good. I've got a really low observed to expected mortality ratio. Probably one of the most important things to show quality. Hey, man, people walk out of RWJ Barnabas. They've got a great observed to expected mortality ratio, and they're taking care of really sick patients. That's a fantastic hospital that I want to go to. And guess what? It's publicly reported. You go to You Compare Healthcare, who are they going to go to? Patients want to go to the best places for care. Let's get RWJ as one of the best places for care. It already is, but we can make it even better pretty simply, documenting all the major diagnoses that a patient has. Here's a quick example of a DRG. So if I have a liver transplant with a MCC, guess what? The relative weight, that means your hospital reimbursement, how severely ill is this patient based on what you document, times your standard base rate. So if you're going to get paid, let's say $7,000 per day, times a relative weight of 11.4, I'm going to come up with almost $80,000 in payment for that illness, for that encounter in the hospital. Number 2 here shows a DRG of 090, concussion, but no MCC or CC. It's probably an 18-year-old playing football, came in on a Friday night, Friday night lights, they got whacked on the head. Well, the relative weight is really low. The daily rate, you admitted them for observation. You're only going to get $5,700 for that patient. Guess what, though? What would have happened if that patient who came in from football happened to be, morbidly obese? Or maybe that patient had juvenile rheumatoid arthritis, probably not playing football, but you understand my point, is if I put extra diagnoses in and they happen to be CCs, maybe not MCCs, and I raise that relative weight up to 1.3 or 1.4, I might get paid $10,000 or $12,000. And if they only stayed in for one day, this is the importance of geometric mean length of stay. Geometric mean length of stay means the average DRG stay for any medical illness. Obviously, liver transplants stay in the hospital a lot longer than a concussion. But what happens if my patient, number 2 here, for whatever reason, ends up staying at the hospital for 2, 3, or 4 days, and I only get paid $5,700? This is not the situation we want RWJ Barnabas to be in. Make sure if there happen to be malnourished or obese or have some other medical problem, that we've got that in the documentation, because it changes the relative weight. You see that in the top one with the MCC. I'm going to get paid more when I do the multiplication rate times my CMS base payment rate. So again, quality is important, PSIs are important, readmissions are important, and hacks are important. Most of these things can be defended against by really good documentation. AHRQ is going to look at these things like your utilization rates of cesarean sections. They're going to look at your mortality rates, your procedure volumes. They're going to look to see how many PSIs you have, pressure ulcers, retained instruments, catheter-associated bloodstream infections, your falls. These are all PSIs. And of course, the dreaded hacks, the hospital-acquired conditions, bloodstream infections, sepsis, ventilator-associated pneumonia, respiratory failure, surgical site infections, MRSA, C. diff. My father, unfortunately, had C. diff after surviving. What did he have? He had, oh, shoot, it's on the tip of my tongue. Anyway, he had pneumonia and he turned to sepsis, and the antibiotics gave him C. diff. He probably got it when he went to post-op rehab. What the heck is that pneumonia called? It'll hit me. Anyway, lucky us, guess what? Just like we talked about the MCCs, all of these quality indicators are subject to change on an almost yearly basis. Let us worry about the changes in the indicators and the quality and the readmissions. But what you can do with your teams is understand present on admission, understand location, severity, understand other diseases and diagnoses that you're actively treating, and teach these things. That will really help. That will help a lot. As leaders, as medical directors, review charts, talk to the teams, talk about these at your lunch meetings. This really makes a huge difference. Inpatient documentation issues. Remember, you're not a coder. I don't want you to be a coder. I want you to understand the importance of great documentation. Be thorough, use the right terminology, use the inclusion of evidence, all the things I mentioned. Again, you're going to get a copy of these slides. Try not to be wishy-washy. Be fairly direct. If they've got it, be determinate if they truly have it. Try not to say maybe. Maybe, probably, and probable is so-so, but try to be as definitive as you can. You may not be sure, but there is evidence in the chart. Discuss that evidence if it's present. Be definitive. Again, take a stand on your clinical judgment. That's what I did for years as a hospitalist. That's what I did for years as a clinical documentation improvement advisor and teaching. And remember, correctly identifying DRGs and severity levels come right out of your diagnostic accuracy. And not only are they accurate, they're specific. You've talked about them in great detail, but you remembered to list all of them in the chart. Here is another great example of what happens if you don't do it right. If you have a secondary diagnosis of CHF because they came in for a small bowel procedure, or I had mentioned some of the cardiovascular procedures, the same thing here happens. If I don't get the right diagnosis, I get a low relative weight, and guess what? I multiply it times my base rate, and I get a low payment. I'm only going to be able to keep that patient in the hospital for a couple days for $12,000 or $15,000. That's not going to help. But if I'm a little bit more specific and I say, oh, they've got CHF, happens to be chronic systolic failure, not just CHF by itself, my relative weight goes up, my multiplication rate goes up. You also see my expected mortality goes up, and I'm going to get paid a little bit more, and my expected length of stay goes up. But guess what? They're having the same procedure, and they've also got acute systolic failure. They've got the right secondary diagnosis. Their expected mortality goes way up. Their expected length of stay goes way up, and my payment can go way up. That's why documentation is so important. And guess what? You're going to see it right now in a pie chart. What's the most common error for proper payment? Insufficient documentation. More than 60% of the time. Yeah, we talk about medical necessity. Maybe the coders made a mistake. Maybe there's no documentation at all on the chart. That's rare. I mean, we always got something, but, and believe it or not, underpayments tend to be fairly rare, but insufficient documentation can really affect your scoring and your payments. So remember, your notes tell a story. Be a great storyteller. Does the record show how ill your patients are? There's only one way to know. I'm immediately going to go to the assessment and plan. A solid physician is a detective and a great storyteller. Hopefully you guys have been glued to the monitor, listening to every word I've told you. So hopefully I've been a good storyteller. A gifted physician is both skilled and constantly learning and attentive. But a truly amazing physician is compassionate, kind, and empathetic on top of everything I've mentioned. So hopefully you're all truly amazing physicians. And I thank you for your time. Again, AHIMA tells us ethical coding is based on really consistent supported health record documentation. It's not inconsistent. It's got good specificity. It's not ambiguous. Like I said, take a stand on the evidence and the treatment and interventions that you took for that patient. Many of these things are linked to the diseases that they have. And remember, we want to avoid queries. We want to avoid post-discharge process. And we avoid that by, guess what? Great documentation. We often ask you to clarify what you said. You said they got respiratory failure and you didn't put in acute respiratory failure present on admission. Because guess what? There's acute respiratory failure after admission, but I need to know. So remember, I told you that. Doesn't hurt. Put POA if it truly is present when you brought that patient into the hospital. And of course, clinical validation is important as well, as you put things in the chart and is it supported by the things that I can find in the documentation? There's criteria for certain diseases. There's indicators for them. There are things that you did in terms of thought process and what you did for that patient, the signs and the symptoms, everything. It all adds up. We can only code and code accurately if we see it in the chart. The number one thing, like I mentioned, is if we don't have great documentation, that's your 64% chance of a denial or a query or a validation question. Be a great documenter, assessment and plan. So CDI team has a function. That's why we hire them. That's why we teach them. That's why they study. That's why they have to do continuing education just like we do as physicians, because they need to get results. It's driven by policy. They've got to do what they do. They're going to be looking at your notes. They're going to be querying. They're going to be looking for compliance. Great notes, you won't get queried. You'll love it not to get queried. So let me stop there. I'll go back on camera. Hopefully this was very helpful. And I will be right back on camera.
Thank you so very much, Dr. Woodman. It was a very comprehensive review. I was glued to the monitor, and I would like to start with the question. Sorry, but what happens if you ignore the post-discharge query?
Great question. So you have people called chief medical officers. You probably have one at the system level, and you have some probably at every hospital. At every acute hospital usually has a medical staff, chief medical officer. You've also got a president of the medical staff or a chief of staff. We follow something called policy and procedure, rules and bylaws. It's a part of our accreditation, whether we do JACO or DNV or any of these accrediting bodies. And in those rules and procedures and bylaws, it'll say, if you don't answer within 24 or 48 hours, or you have queries and we do statistics and analytics on this, and if you're constantly a person who doesn't answer these queries, it's a danger to the hospital in terms of payment and quality. But depending on how your rules and bylaws are written, you could get fined, you could potentially be suspended. It's a slap on the wrist if the CMO has to come and talk to you. We don't want that. We don't want it to go to MEC, the Medical Executive Committee. We don't want it to be taken any higher. So do address those queries, whether they're usually CDI clarifications prior to discharge or post-discharge coding queries or clinical validation questions. Great documentation will avoid that, like I mentioned, but whatever your local policy is, and I don't know your local policies, but it was a great question. If you get something, we call them love letters in your in basket, please answer the love letter. It's important.
Okay, now I will.
So here's a quick story. I was working at a hospital in California, and there was a couple of folks, and the statistics always showed they were the people who were late with their discharge summaries. They were late with answering queries, and we put in an electronic system to try to improve it. Guess what? They were the same people who perennially are the ones who weren't answering the questions or responding to the love letters. It tends to carry forward. There's always folks like that. The point being, through education and support, the tap on the shoulder from, the medical director, the CMO, hey, we've got to do this. It's our obligation. Again, it's a team sport. Don't make someone else on the team do it. Take one for the team. Answer the questions.
Thank you. Let me ask another one.
Okay.
You give the example, liver transplant with comorbidities is reimbursed at the level of about 80,000. What about if it is a liver transplant without major comorbidities? How big the fork can be?
Yeah, that's a good question. As those, it's very unlikely that someone with a liver transplant, even electively, doesn't have a list of secondary conditions. You've heard the discussions of the past about poor protoplasm or poor genetics, whatever it happens to be, drugs, all the associated things. But what happens when you don't have those MCCs or CCs, the relative weight will drop very low. And you do not want to get potentially a reimbursement rate of, say, 40 or 50,000. It's still a high number. But here's the biggest thing, and it's a simple math equation. We did this at my hospital in Georgia, where I mentioned to you that they made $30 million. Our one flagship hospital did somewhere between 100 and 150 daily discharges. It was a very big hospital and very busy. What's 100 times 1,000 on a daily basis? If I missed $1,000, I lose $100,000 a day. Heaven forbid. What is that over a month, though? 30 times 100, that's $3 million a month. Nobody wants to lose money like that. So again, it's important to document as many diagnoses as you can and make sure that you come as close to your relative weight for your full reimbursement for the illness of that patient. And again, great care, like I mentioned, for the observed to expected mortality ratio, also helps for geometric length of stay. Because if I have a geometric length of stay of 11 or 12 days, but the patient does well and they get out at 9 or 10 days, I send them to rehab or they actually can go home, God willing, I'm going to have a pad. I'm going to have a little extra reimbursement. That's really what we want.
Thank you so much. I do not see any raised hands and there are no questions in the chat. So I want to thank you very much on behalf of all of us and also on behalf of Dr. Sengupta, who had to catch the flight and was unable to join us tonight. But we appreciate the talk. We appreciate the visit and looking forward to hearing from you again.
Sure thing. And if you see this face on Wednesday in New Brunswick, please say hello.
We will.
Have a great evening, everybody.
Good night. Thank you.
Bye-bye.